All right. So, for all of those who are able to attend, Laura, um, this is a case that I saw several months ago. But a patient came in with low back and radicular type pain and left greater than right hand paresthesias with weakness. Let's see if I can get the slide to move to the next slide. She was a 46-year-old female, had low back pain extending to her hips and the posterior right lower extremity all the way down to her foot. So same sciatica. She'd had those symptoms for about a year. She does have a history of a right femur fracture with an ORIF, and it was revised in 2017. She had a left total hip replacement in 2018. She also complained of bilateral hand paresthesias, including the whole hand with weakness, and the duration of those symptoms was 6 months. So if we look at that, anything, just
Oh,
patient,
yes.
yeah,
Like, what am I thinking right away?
yeah,
Well, obviously, it's possible she's got a lumbar radic.
yep,
Um, you know, I'd be curious about that femur fracture with the RIF. I know it's further down, but you always wonder if there's any kind of nerve entrapment with anything with that.
okay.
Um,
So
I mean, yeah,
rule
I would
out a
just
proximal sciatic neuropathy
exactly.
versus
I would
lumbar radiculopathy.
exactly. I would rule out something proximal like that.
Good.
And the bilateral hand paresthesias. I mean, I'd be curious to know if she has an overlying, poly or something that maybe, you know, something like that could be mimicking the um, the right lower extremity to the foot on that right side. But the fact that she has bilateral hand paresthesias, maybe she's got something with that, overlying.
Okay. So in the clarifying exam, she had pretty significant APB atrophy, and her ulnar intrinsics were like 4 out of 5. She had light touch deficit in both the median and ulnar nerve distributions with intact muscle stretch reflexes. No long track signs. She did have positive Durkin's compression at both median nerves at the wrists. So an upper extremity screen sounds like what?
Well, she's got deficit. I'm just reading it over again. Light touch deficit, median ulnar, that's AP. Well, she definitely has some median nerve, possible axon, something going on there, especially with the atrophy.
Hmm.
Definitely something going on with that ulnar nerve distribution.
Okay.
So we're either looking at something lower trunk, possibly too. I don't know. Oh,
Well,
no, because it's
what's the
bilateral.
sensory
No.
what's the sensory distribution of the median nerve with respect to the plexus?
Well, the median nerve is the first three digits.
And
Is that?
what's that distribution? What is that distribution trunk-wise?
Oh, true. Right. That would be considered the upper.
Hmm.
Yeah.
Upper middle and
Yeah.
anterior divisions and lateral cord.
Upper middle, right. Upper middle anterior, right. Yep.
Yep, upper middle trunks, anterior divisions, lateral cord, median nerve. So it
Okay.
looks like median
Median nerve.
neuropathy with possible ulnar neuropathies.
Correct. But it's
Uh,
both hands.
it is bilaterally, yeah. So she doesn't have really good effort in her lower extremity. Um,
Now, did she have atrophy in the right APB as well?
I don't think so. We'll check
Like
her
with
study. We'll check her
just
study and see if it correlates here in a minute.
okay.
But I don't believe so when I wrote this up.
So the strength deficit was more the left hand, not so much the right, in terms of the APB.
The APB atrophy was very weak with weakness and atrophy in the left hand. And again,
Right. Okay.
excuse me, here in a minute we'll try and correlate that if we see anything in the nerve study that would confirm that. I'll be able to answer that in a minute. I frankly don't remember this case.
Okay.
Um, I don't remember sitting and doing her physical examination. I remember performing the case, but I don't recall. I
Right.
thought I noted what was pertinent.
Okay.
Okay, so in her lower extremities, she had variable strength, normal muscle stretch reflexes in her knees, but they were absent in her ankles. She didn't have any long track signs in the lowers either. Sensory screen was clean. She did have some notable edema. She had a negative straight leg raise, and she walked with a walker.
Wow. So she had
So,
absent ankles. So she had absent ankle,
yep,
S1, regular, normal in her quads. So no cord signs. Sensory screen was normal on her legs. Okay, but edema on her distal ankles and feet. Okay. All right.
and so what's based on what we see here? Nothing really different, right? You've got
No.
so here we have some atrophy weakness, some muscle stretch reflex abnormalities bilaterally in the ankles, but fairly normal sensory screen in the lowers.
Right.
She walks with a walker, but she's had a hip replacement with revision and then the other hip done. So, but she's only 46 years old. She's younger than us, younger
Yeah.
than
Yeah.
me. She's probably your age,
Yep. All right.
but seems young. So in this case, when I read her referral, it was bilateral hands and then what appeared to be lumbosacral radiculopathy. I actually saw her on two separate occasions, once for her lower extremities, and then I had her back a week later to see her for her uppers. And so when I did her lower extremity nerve study, what does that look like?
All right. So she's got good sensories. Motors look good. Everything looks good in the onsets and the latents in the conduction velocity.
Yep,
Amplitudes look good.
they don't
Everything
look
looks
great.
normal.
Sensory
Yeah,
amplitudes don't look great though.
right, but they're not below normal. I mean, they're low,
They're
but
not
they're
below
not.
normal, but they're low limit of normal.
Okay, that's a superficial peroneal, and that's the right side.
hmm So I don't
Okay.
know that I would say that
What
that's significant. She also had she was kind of cankly, right?
do
She
you mean?
she had
Oh,
swollen
the swollen.
ankles.
Yes, correct. Yep.
Yeah, so she had some swelling. Hey, we got another member. Hey, Bill.
Hey, big. How are you, sir?
Doing great, man. Hey, Laura, do you mind if we back up a sec and just catch Bill up?
No, go right in.
Uh, if I can do it.
Sorry about being late.
Oh, that's all right, man. I'm glad you're here. So, Bill, this is a lady that came in a couple months ago, 46-year-old female, low back pain, right radicular symptoms. She'd had the symptoms for about a year. She, uh, over a year ago, had a right femur fracture with an ORIF and revision, and then within 6 or 8 months, had a left total hip replacement. She's got bilateral hand paresthesias with weakness, and that's been over the last 6 months. She had atrophy with weakness in the APB. Ulnar intrinsics were a little weak. Median ulnar light touch deficits, positive Durkins, but no other long track signs in the uppers. She didn't give a lot of effort in her lower extremity strength assessment. Had absent ankle jerks, 2+ knees, no clonus. Sensory screens fairly normal. Had notable edema in her distal ankles and feet. Negative straight leg raised, and she used a walker. 46 years old, but less than a year out of hip replacement surgery. But at end of day, she's young. So this was her lower extremity sensory and motor nerve conduction. And Laura had indicated that everything here looked pretty clean. Um, I commented that the sensory amplitudes are at the low limit of normal, but again, there was notable edema, and that could be just body habitus and swelling with low limit of normal stuff. And that's pretty much how I write those kinds of things. If I were writing this, I would say that the sentences that I would use, I would say bilateral sural and right superficial peroneal sensory latencies are normal with amplitudes at the lower limit of normal. And that's how I would describe that in my narrative summary of my nerve conduction study. And then I would say that the bilateral tibial and right peroneal motor nerve conduction studies were within normal limits, because those look fine to me. You guys cool with that?
Mm-hmm.
Good. Okay. F waves. Reasonable. H reflexes. Reasonable. Right, the left at the upper limit of normal comparatively, but still falls within normal limits.
Mm-hmm.
Her EMG.
Yep. Increased. Erroneous longest. Increased. Tibial. One. Tensive ladder. Increased. So we're looking at something with S1 on the right?
So make a statement.
I'm just trying to read.
If you were going to
So
write it, so as you read that table, be in the habit of summarizing the table as you see it, because you saw it just right.
mm-hmm. So there is increased insertional activity and spontaneous activity with 1 plus fibs and positive shock waves in the S1, medial gastroc, peroneus longus, tensor fascial ladder, indicating axonal involvement of the S1 nerve root.
Okay, I'm okay with that. Or at least you said membrane instability, muscle membrane instability in several muscles from the right lower extremity and lumbosacral paraspinal sharing the S1 distribution. Something along those lines.
Mm-hmm.
Now, what does that mean? So what else is normal, abnormal?
Well, we also have the gluteus medius and the superior gluteal came back normal, but that's and then you also have the no, I'm sorry, I'm looking at that's left. Never mind. I'm reading that wrong. I was looking at the left medial gastroc, but that was normal.
Mm-hmm.
So we have normal L4, L5 in the deep for the anterior tibialis. We have a normal femoral. We have a normal superior gluteal. So L4 through S1. So yes, I mean that at a process of elimination, I would say that it definitely would be more S1.
Yeah.
Is that what you're asking?
Yeah. Well, I'm asking that, but what is it about what is this an acute problem, an ongoing problem, or chronic problem?
Well, being that there's no polyphasics and the amplitudes are normal, and it's increased insertional activity with the muscle membrane instability, I would say it would be more an acute situation.
Okay. Is it mild? Is it moderate? Is it severe?
Mild. I'd say mild
Why?
because it's only 1 plus with the fibs and the positive shock waves.
Anybody
Right.
else?
And there was no change.
I'd agree with that.
You would agree with that it would be mild just given the profuseness of fibs and positive waves? How about you,
Just
Bill?
not on its severity.
Because it's involving so many muscles, it sounds like it might be something a little bit more than mild.
Well, I would say I would agree with mild, but I wouldn't say that it's mild simply because of the profundity of the fibs or positive waves. You're not going to see necessarily you may see some correlation, but it's not a super strong correlation in how many fibs and positive waves versus how bad a denervation. You would suspect that it would be, And a lot of people will do that, but others will argue that, look, oftentimes the amount of fibs and positive waves have a lot to do with reinnervation. And so it's hard to predict how bad something is. It could be that this is only, a few weeks old and it hasn't had enough time to have lots of fibs and positive waves yet.
Hmm.
Or in a case where there was a more severe injury and you'd had reinnervation of muscle, then you're going to see fibs and positive waves decrease due to reinnervation. But there's another component of this table that would help me to decide how bad it is. And it's not the presence of fibs and positive waves. In fact, it's not the center of the table at all. It's more all the way over to the right, like the last three columns.
Well, there's normal recruitment. There's no polys,
Yeah.
and
So
it's
even the presence of a polyphasic or a large amplitude motor unit isn't going to help me with how bad something is if I see significantly reduced recruitment with rapid firing and a poor interference pattern. Then I'm thinking that this is a, a more significant problem than just the presence of fibs or positive waves. So I would agree with the statement that this is mild. Um, I would agree with the statement that this seems more acute because of the lack of motor unit morphologic change, and the reason that it would seem more mild to me, I'm okay with that. There's only 1+ fibs and positive waves, but really the fact that she's capable of recruiting muscle normally with reasonable interference patterns in her EMG without a lot of rapid firing recruitment is indicative of the presence of lots of available motor units, and it's uh, not quite as severe.
mhm.
Is everybody buying that?
Yep.
Yep.
Good.
Hey, Rick, can I ask maybe a little bit off-topic question, but kind of relates here. On the paraspinal EMG, initially when we started our training, we we kind of stayed away from looking at the recruitment, and I'm seeing this inconsistently showing up depending on that. What's your take on looking at paraspinal recruitment when it comes to EMG?
I I will comment on it when I see it in a patient that has a difficult time relaxing. More so if I'm able to isolate units. Um, it's it's not as easy to isolate units in paraspinals. It's not hard,
Agreed.
but it's not real easy, and it hurts.
Yeah.
Um, and to me, you're going through. I try to sample when I'm listening to insertional activity and resting activity. I'm going deep. I want to bounce off a lamina to ensure that I'm in multifidi, because it's at those levels that you have better detectability of a specific level.
You bet.
Um, so when you're in the first superficial layers of paraspinal muscle, um, when you contract those muscles, the uh, the length changes differently depending upon which level you're in, and and I don't want to shear a needle off in a patient's back.
Mm.
Agreed.
So I just don't do a lot of recruitment in paraspinals. I've pulled several needles out of patients' backs that are bent at about a 45-degree angle
Yeah.
because of patients that arch their back or jerk. And I try to be a pretty nice guy when I'm testing, but that's when I get mad with a patient. When a patient threatens their safety and mine, then I have a hard time. But I know it hurts. So
Right. Right.
I just try to avoid that if I can. And so as a rule, or as just it's not a rule. I don't go after trying to look at paraspinal EMG activity, and there may be lots of people that do, and they may do it well. I just don't myself.
Gotcha.
But it's absolutely okay that if you do, um, and maybe I should. I'm open to doing it. I just haven't. I don't know that it's affected my ability to say what I need to say.
There you go. There you go. Thank you.
hmm So, so for those that came on the call a little bit later, this is a 46-year-old female, low back, uh, right sciatica, I believe it was, and also that was of about a year's duration. She year and a half ago had a hip fracture with ORIF, and 6 months previously had a total hip arthroplasty on the other side. Um, she also had bilateral hand paresthesias that involved the whole hand. She had weakness with atrophy in one APB and like 4 of 5 strength in ulnar intrinsics. Um, she had diminished uh, ankle jerks and anything else notable? Positive Durkins bilaterally, I think. That was about it, wasn't it, Laura?
I believe so.
Okay. So this is an example of how I would write. Um, so the sural right superficial peroneal sensory nerve is normal. However, amplitudes at the lower limit of normal. Bilateral tibial right peroneal nerves normal. Tibial H reflexes, F waves, right peroneal F waves normal. Membrane instability noted in the right medial gastroc, peroneus longus, TFL, right L5S1 paraspinals. All other muscles representing L2 to S2. Left lower, right mid, upper lumbar, right lower thoracic demonstrated normal insertional resting activities. So these findings suggest an acute compromise of the right lumbosacral nerve root at or near the S1 level. Insufficient evidence of any other peripheral mononeuropathy, polyneuropathy, plexopathy, or myopathy.
So at this time, you didn't do anything in her upper extremities. You said she came back a second visit to do the uppers. Is that what you
That's
had said
correct.
before? Okay.
Yeah, this was in a neurosurgery practice. Um, they will often see suspected, cervical stuff and then suspected lumbar stuff. And so when it's a multi-limb case and it's not evident on the first visit that it's just, if it's a polyneuropathy and I can get it done in a few extra nerves, then I'll go ahead and do it all. But we'll send the patients away and then have them come back so that I can complete the whole test. It's, if you stick 20, 25 muscles and then do 12, 13, 14 nerves, that's just a lot on a patient to me.
Mm,
And
yeah,
so
absolutely.
so I'd split it up and let the patient know. And oftentimes I'll just say, which one bothers you most. Um, and then we'll start with that and then say, I'll see you next week and we'll get the other part done. And usually
Right.
when I finish the, like in this case, if I was finishing the lowers and I finished the last paraspinal stick, I'd say something like, okay, so we're halfway done. Are you ready to do the uppers?
Hmm.
And they'll say, no, I'll wait till next week.
Yeah.
Because sometimes they'll say, what, we're not going to do it all today? And I'll say, no, you're probably going to prefer to wait. And it's a lot of stimulations and a lot of pin sticks. And, we'll schedule you. So when I finish, usually I'll say, okay, so you ready to do the next part? And they'll say, no, I'm going to keep my appointment for next week.
Hmm.
So, okay. So the following week she came back. And who wants to summarize this data? Laura did Shelly is on and Bill is on, and they've muted. Is it okay to unmute, guys?
Yeah, you can unmute them. Okay. So looking at the sensory table, I'm assuming I'm elected here.
Sure.
Yeah. We are seeing, let's get at the left median sensory, we have a slow NCV at that transcarpal, no it's not, yes it is, segment at 19 meters per second. Looking at the latencies there, jumping back for a moment, we've got yours just bowled out. I'm used to the red boxes of death here, but I'm assuming that the 5.6, when we're bolding, you're helping me along just a little bit here, and that latency is also slow.
Next time I do one, I'll leave them unbolded for you if you want.
Thank you. That's all right. So yeah, so we have prolonged latency and some slowing at the left median nerve, that transcarpal segment. We've got, let's see, a normal NCV as well as latencies at the right median sensory. We have at the left ulnar sensory, we have prolonged latency, decreased amplitude, diminished amplitude, and nerve conduction velocity, which I have not memorized what it ought to be here. What's our standard there, Rick? We're at 33 meters per second.
We want it less than, on here, we want it less than 3.4 milliseconds, so I don't report normative velocity because the latency and the velocity are proportional.
Okay.
So whatever 12 divided by 3.4 is would be the lower limit of normal. Or the upper limit of normal, sorry.
So,
but I don't report that simply because the latency and the velocity are the same thing. I don't ever say that, I would just say that bilateral ulnar sensory latencies are mildly slow
yeah.
with low amplitude on the left and lower limit of normal amplitude on the right.
Okay. And you did some comparisons here of the median to radial with a prolonged latency of the median on the left and as well on the right.
And anything else there?
Let's see. I'm not seeing anything else.
Amplitude. There's an amplitude difference.
Mm-hmm.
Oh, on the comparison study? Yep, there is up there.
And if we look up, and because I'm going to ask Bill to summarize this in a couple of sentences here in a minute. If you look up at the left median D3 wrist to digit, what happens to that amplitude? We sort of
really drops. Yeah. Yeah.
So what is that called?
Less.
What is that called?
So if we have a decrease in amplitude in that distal, it is at the distal segment, we've got a conduction block there.
Well, it's the proximal segment that the amplitude drops.
Yeah, that's where it's dropping.
So again, for practice in writing, Bill, do you want to take a stab at being more concise, a little more concise in the description of this sensory table?
Yes, I really just am excited about this.
Oh, Bill.
I'm ready to get you back.
Let me put I want to be back. I'm putting my drink down and my dog down.
All right.
All right. So there is, with respect to the left median, third digit sensory, there is decreased, decreased slow latency, moderately slow latency, and moderately decreased or moderately diminished. Shoot, I can't even. I'm on the shit.
It's okay.
Decreased nerve conduction velocity at the wrist.
Yep. With partial sensory conduction block.
With partial sensory conduction block. On the left, because these guys are, they're so different. So I'm going to say the left ulnar sensory fifth digit has decreased, prolonged latency,
Mm-hmm.
slight or minimal on that. Diminished amplitude with normal, well, you don't say, well, you can't say anything about the conduction velocity because there's nothing there.
But again, the conduction velocity is not applicable.
Right.
Because, see, and does everybody understand that? If the latency is the value in a sensory nerve, latency and conduction velocity are essentially the same thing over a
Right.
standard distance.
On a sensory nerve, you said?
Yes.
Yeah. Okay.
The only time that it would matter to calculate a velocity on a sensory nerve in a single segment, the only time that it would matter is if you deviate from a normal distance due to some modification in the patient's anthropometrics. So, for instance, you needed to extend the length of a nerve from 14 to 16 because of the size of somebody's hand. Now you can't use your standard latency, so you're going to need to modify your norm for the alteration in length.
What about because of scar tissue or skin grafts or anything like that?
If it affected the length, of the segment you were going to look at, then yes, it would affect that latency norm. Now, one thing that scarring and grafting and swelling and those kinds of things might affect is amplitude, just because of the increased resistance in the tissue. And so you may see lower, big calloused hands, that type of thing. You may see lower amplitudes, but it shouldn't affect the latency or the velocity.
And the right sensory digit 5 has prolonged latency, minimal prolonged latency, and normal amplitude, or how did you say that on the normal amplitude? But
amplitude at the lower limit of normal, something like that.
That sounds good. And then there's then comparison table, say the left median radial comparison shows an increase, a prolonged latency with the median sensory nerve, and then an increased delta or differential between of 1.7 or actually that's considered a moderate, or maybe even is that a moderate or severe?
Yeah, it's a moderate. This is a moderate median neuropathy at the wrist, but I will know when we check her motor stuff. But right here, I would characterize this data as moderate on a severity scale. Now, if I were writing this, I would work to be, as we've talked about in our report writing workshops, trying to be as concise as you can and organize the data based on the patient's problems. And so the problems that I see when I look at this, if I look at the whole table, instead of just looking at one nerve, if I look at the whole table, I'm going to break this table down as to what's most significant. And what jumps out at me as being most significant is the left median sensory studies. And then less significant is the right median sensory comparison to D1. And then the slowing and low amplitude ulnar stuff. So if I were going to write these sentences, I might say the bilateral median sensory nerves demonstrate delayed latencies to digits 1 and left digit 3 with partial sensory conduction block at the left wrist and slowed transcarpal velocity. So I just tried to characterize what the median sensory stuff looked like in a single sentence. The bilateral ulnar sensory latencies are mildly delayed with mildly low amplitude on the right and amplitude at the on the left, and lower limit of normal on the right. Bilateral radial sensory nerves are within normal limits. And so in a few sentences, you want to try to capture the essence of what the table's telling you when you look at it, because every one of you looked at it and could see what the problems were if they were bolded in front of you. But our job is to try to describe, to tell a story in our report so that it makes sense to the reader. One, what the problems are. Two, organizationally, what's most important. What am I going to look at? And if I were a surgeon, I would want to see that, what do I need to do first with this patient if I were planning to operate on them? And it might be the left median nerve. So hopefully I've highlighted by order what might be most important to him or her, whoever it was that was doing that. Now,
before you go on there,
yeah, you want me to go back up?
You did the sensory comparison from median to radial because from what we talked about on a previous webinar, because of that brachial plexus screen that you like to do. Is that correct? Because when I would do this, Rick, if I just had the data that I had on my sensories, I wouldn't see anything compelling me to do a comparison study here. Do you know what I'm saying?
I do, other than the fact that you would have said that the right median sensory nerve was normal, but the patient said she had bilateral hand symptoms.
Oh,
So
in her report, she says she's got bilateral hand symptoms, and we picked up that the right.
Yeah, we picked up that the right was involved. So I wouldn't necessarily disagree with the decision maybe to stop if you were doing a left-right comparison and she had no symptoms on the right.
Yeah.
But she had symptoms bilaterally that were median and ulnar. But she had left APB weakness that was severe. So if you had done that study that you just described and said, okay, I'm going to do long segment, short segment, one median nerve, and you'd have missed it.
Yeah. When I look at the right median antidromic sensory, I see a nerve conduction velocity that's right on the edge of normal.
It's really
it is
not.
normal.
It's
Sorry, it is
44.
normal. It's 39.
Normal.
Yeah.
And that looks completely normal. Yeah.
And my my latency is normal, but just barely. So sometimes I look at those types of things to get to, do I need to do a sensory comparison here? So okay, yeah. that does make sense.
What drove me was the fact that she had symptoms, Bart.
Yeah, and that does make sense too. As a lot of times I'm trying to keep myself away from kind of hunting for pathology only based on their symptoms, but that's listening to her symptoms and also looking at those numbers, how close they are.
Yeah, I mean, if a patient came in and had a positive Durkin's compression test, said I have nighttime numbness and tingling, it gets better when I shake my hands, and I do the median sensory D3 on the right, and I get that data.
Yeah,
I'm going to do the median radial comparison to D1 or the median ulnar comparison to D4.
Right.
And if one of them's like 0.4, I'm doing the other one too.
Gotcha. Okay. Thank you. That's helpful.
Sure. And at the end of the day, if I didn't see any abnormality, I'd call it, despite symptoms of of carpal tunnel, there's not sufficient evidence of median neuropathy of the wrist.
Right. And I
And
do
if
see that often, actually.
Yeah, and if any or all of those are positive, then I just updated my severity scale to very mild.
Yeah. Yeah.
Is that cool?
Yep, that's great. That's very good.
This looks a little more malevolent.
Mhm.
Very low median amplitude and slow. Now, I didn't shock her in the palm, but it's okay. It's very low. She had atrophy. She had significant weakness. Short segment transcarpal on the right is slow. The left ulnar is low in amplitude. Bilateral ulnar is low in amplitude. Delayed latencies. Slowed NCV across the right elbow. Low limit of normal in the left forearm. Slow across the elbow to the left FDI. Slow in the forearm and across the elbow in the right FDI.
So would you say that because of that amplitude that we're seeing with the left median motor, that already characterizes, even before I do a needle EMG and that APB, that already characterizes in my mind that she's in severe?
Yeah.
Yeah.
Yeah, for sure. Anybody argue with that? And the fact that your ulnar CMAPs are low is not
Yeah.
good either. They're slow and low. And here we're thinking we're dealing with just ulnar neuropathy at the elbow, because that's where, I've been on record that says if you see ulnar symptoms, the problem's at the elbow, and do everything you can to demonstrate that this problem's at the elbow. So I alternatively tested off the FDI to see, is this at the elbow? And sort of looks like it is on the left, but heck, to the ADM, the cross elbow is better than the forearm. But to the FDI, it was slow at the elbow. But the latencies are slow, and those are significantly slow. Usually, if you see low amplitudes, you might see a little slowing in the distal latency. If normal's 3.6, you might see 3.6, 3.7, 3.8. You really don't ever see it above 4.0 unless it's just shot. But she still got some preservation of CMAP, 3.6 and 3.0. But those are low for a 46-year-old female. Anybody have any comments or questions about these tables?
So you went to the FDI and reperformed the ulnar motor tests to be able to see if the most exposed axons, which tend to go to the FDI with ulnar slowing at the elbow, are affected. That was the rationale. Is that correct?
Yes. Yes.
Okay.
Particularly on the left. Wasn't as necessary on the right, but I found it very odd that I would see such a slowed latency on both of the ulnar nerves. And frankly, given the fact that her snaps were preserved, even though they were lower limit of normal on one side and just barely low on the other side, I would have expected to see normal CMAP amplitudes. but I didn't.
And when you
So
say you would expect to have seen it, it's if we had a more typical cubital tunnel problem or focal entrapment at the elbow, you would have expected to see better amplitudes on those C maps.
yes, yeah, you're going to see by the time you start recognizing amplitudes below the lower limit of normal in most focal neuropathies, your snaps are very low or gone.
Okay, that does make sense.
Uh-huh. So I just didn't expect to see that, particularly the slowing at the wrist in the latency. So it is what it is here. But this is complex. This is a complex um, group of findings. And if somebody were brand new doing nerve studies and I got this data set from them, I would, with a new trainee or a new partner, I'm questioning the integrity of their data. But I've been doing this for 23 years, and I've done a lot of cases. And I did this case. I did not do the lower case. That was one of the guys that works with me. But I did do this upper. I'm the one that saw her the next week for her uppers. And so there's her upper EMG. So we see most significantly reduced rapid fire recruitment in the left APB. So I would say that there's evidence of severe ongoing denervation in the left abductor pollicis brevis, greater than left first dorsal interosseous, with some evidence of mild ongoing denervation in the right ulnar FDI. Remaining muscles in the screen from the bilateral upper extremities representing the C5 to T1 distributions demonstrate normal insertion, rest, and volitional activities. Something along those lines. Well, yep, that's pretty much what I said. So that's how I wrote her upper extremity study. Everybody having an opportunity to read through that.
Yes, sir.
Now, for those that were at the Bart and Laura at the symposium, Dr. Kimura spent some time on this type of case. Do you remember? And it was one of the first slides he put up.
Remember.
Do you remember?
I can't. I'm trying to remember what he put up.
Do you remember, Bart?
Talking about ulnar neuropathy specifically at the elbow?
No. When he was talking about polyneuropathy.
So he was
said
saying about people who have like underlying conditions with polyneuropathy.
he was talking about the way that polyneuropathies present. He said that a lot of the polyneuropathies that you see are going to be length dependent. They're distal, they're symmetric. So you'll see distal symmetric length dependent polyneuropathies. But then he had a whole other category where he said
Oh,
these
yeah,
really don't fit, and he called it mononeuritis multiplex.
that's
Oh,
right.
right. It's all coming
Okay,
back.
and he described how in a mononeuritis multiplex you may see a patient come in one time with their left arm,
Right.
and
And
then
then it's
6 months later with
it's the
their
other
right
arm.
leg, and
Right.
then 6 months later it's the other arm.
But this patient came in with complaints all at the same time, both
But
hands and her
but when
leg.
did they begin?
I don't remember. I have to go back to that first screen.
Want to?
Symptoms for a year. Oh, okay. Symptoms in the hands were 6 months. So,
Which
but she's
actually
had the.
correlated pretty well to the event that she had with her total hip.
So did she have the low? She had the leg symptoms first, and then
Yep.
6 months later she brought on the hand symptoms. But she still had the leg symptoms at the same time as the hands, though, right?
Yes.
That actually makes very good sense as far as the pattern of arrival. A lot of patients, when they're on a walker for a long period of time, they tend to have paresthesia to the hands and also elbow problems too, or you
Hmm.
know. So it sounds like that makes a lot of sense to me.
Yeah, it could. Coupled with the fact that her body's just got brand new hardware in it, could she be having some type of autoimmune type of inflammatory problem with her nerves? Could she have any other underlying hereditary neuropathy?
You said she was on
HNPP as an example.
you said she was on a walker still, right?
Yeah, she's still using a walker. Yeah,
I'll
And
tell you
there's
right
no.
now, if you've been for a year, that sounds like
that's a
it's
long time. And she's 46, guys.
yeah.
She's not an old person either. So those nerve studies in a 46-year-old are not normal.
Right.
So abnormal study with complex multiple mononeuropathies. Evidence of severe bilateral ulnar neuropathies involving motor greater than sensory axonopathy and demyelination that's difficult to assess focal involvement. The majority of ulnar neuropathies do occur focally at the elbow, and there's evidence to corroborate this. However, distal motor sensory latency measures provide abnormal data, making confirmatory foci difficult. There's severe left and very mild right median focal neuropathy that appears at the wrists. No abnormal proximal C8T1 or other neuropathic findings in the remaining screen from the bilateral uppers to suggest a more diffuse process. Prior study of the bilateral lowers last week did identify right lumbosacral radiculopathy. Therefore, there are collective abnormalities compelling of more multifocal neuropathies.
Did you do cervical paraspinals? I didn't notice.
I didn't.
Oh, okay.
I don't think so.
With that multifocal neuropathy, the mechanism here is the mechanisms can be very diverse, if I'm understanding that correctly. We can have
Yes.
some
Now,
type of
don't confuse multifocal neuropathies with MMN, with multifocal motor neuropathy with evidence of conduction block. It's not the
right.
same phenomena.
Well, on this complex multifocal mononeuropathies is just a rare scenario where it's like the perfect storm for multiple nerves at any possible entrapment, and they just kind of at random, or maybe not random events, we get some type of massive inflammatory situation. We may not know what the pathology is, but this is what you're reading. You're saying, hey, the evidence, the electromyography, our evidence here shows that we just have focal neuropathies everywhere and pretty severe for both age and any other condition that the patient may have.
Rick, was this a
Yeah.
big lady?
I'm sorry, Bill, I didn't hear.
Was she a fairly large individual, or?
She wasn't really fit, but I don't recall that she was morbidly obese. She had a little bit of swelling in her legs, but
Yeah, I'm just
no, if she had been morbidly obese, I would have written that in the description.
I'm, I'm going to say this as a clinician, for just not on the electrodiagnostics aspect of it, but a clinician has seen tons and tons and tons and tons of patients that have been on walkers for a long period of time. I
Yep.
mean, they always complain of, I mean, they always have, and not always, take that back. Many times, especially females, tend to have bilateral paresthesia to the hands and the ulnar nerve distribution. I would be very hesitant in saying this is some kind of some kind of whole body issue. If anybody's ever been on a walker for that long period of time, I promise you're going to have some carpal tunnel issues. You're definitely
Well,
going to have.
that's exactly what I was thinking too, that she's been on this walker for a year since the onset of that injury, the surgery a year ago. And, if she is out of shape and she's using the walker and she's putting a lot of compression through the wrists and strain, and possibly, who knows what she's doing with the elbow. I was just wondering if that could be the case, that maybe she just developed these problems in both hands and
I think once
elbow from
presenting,
being on the walker.
And I think that mechanism totally makes sense at the wrist. I'm a little bit unclear at the elbow, but it's not out of the realm, right?
It's not unusual at the elbow either, just given the amount of force with gripping and flexor compression of what torque that's going to place on the ulnar nerve at the elbow.
Yeah.
So that's not. I mean, I don't disagree with that.
I'm not trying to veer off
No,
into different
no,
elements.
I don't think that veers off at all. It gives it gives you an idea of potential plausible reason why here's a patient that's had all this stuff, and why is so it could she be having um, Guyon's canal ulnar neuropathies, severe unilateral carpal tunnel, um, some evidence of some ulnar stuff happening at the elbow. The problem that I see with it is that it we're trying to put in a can a reason why a patient presents this way, and I just don't see otherwise 46 healthy 46-year-old people um, remain on a walker six months to a year after having had hip surgery, um, and develop these types of symptoms. But so it makes me wonder if anything else is underlying here. I mean, why is she having these neuropathies? Could it be because of compression? Maybe. Could it be because of comorbidity and compression? Maybe. Could she be having some type of autoimmune? Could she have an underlying hereditary issue that leads to this? Maybe. But do we need to do bilateral carpal tunnel surgeries, bilateral ulnar neuropathy at the elbow surgeries, bilateral Guyon's canal decompressions, and a lumbosacral, and a laminectomy? I, I don't know.
Yeah, that really pissed our system off.
Wouldn't it though?
Yeah,
Well,
my.
and at the
So,
same time,
How
I was just
about,
going to say
go ahead.
that compression of the median nerve there, something's got to give there, or I mean that's severe, very severe.
yeah, I would advise if I were her surgeon, I would probably want to decompress the median nerve at the wrist.
Yeah.
And she needs to get off the stinking walker. I mean, that's good advice. Move to a loft strand type of device if you're going to have to continue to use it. But lady, you're 46 years old. You've got to you got to get off of these assisted devices.
Yeah, the lost strand's going to put pressure on the ulnar nerve.
Yeah, but I mean, you're educating a little more, at least in the forearm.
Sure.
and be off of it more so than you're not gripping as hard. But at the end of the day, from an
Awesome.
electrodiagnostic perspective,
Yeah.
this is a case of mononeuritis multiplex, painful asymmetric sensory motor primary axon loss neuropathy, involves at least 2 separate areas of nerve. Random areas of the body can be affected, can be bilateral, distal, and proximal.
Great.
Etiologies, infection, that's a biggie. Autoimmune disorders, chronic systemic conditions. I wondered in seeing a case like this. Here we've had a girl that a year and a half ago had hip ORIF. We just introduced new stuff into her body. 6 months later, had a total hip arthroplasty on the other side. What's her body doing accepting this stuff and these multiple surgeries? And how has her body reacted?
I would ask how much nickel was in the total hip replacement.
Yeah, I don't know.
A lot of women are having hard times with the nickel right now.
No telling. But that sort of correlates with her hand symptoms kind of started after her total hip arthroplasty. But hell, I'm sure she used some type of assisted device for the 6 months between her hip fracture, ORIF, and her contralateral hip arthroplasty. But why is a 46-year-old, I mean, I guess I didn't ask, how'd you break your hip?
Mm.
Why are you 46 and having a hip replacement on the other side? You're awfully young.
And how did she do that? Why did she need the ORIF too?
Yeah. So how'd you break your hip
Yeah.
to require the ORIF, and how come 6 months later you had to have a hip replacement? You're younger than me, and I'm fat.
But you're cute.
Well,
I am.
I was going to say the typical 46-year-old hip replacement that I've seen in the past has RA, some autoimmune. So that's interesting.
Mm-hmm.
They're also severely deconditioned too.
Mm-hmm. And I mean, she wasn't a rock star. She wasn't a collegiate athlete.
And what was the cause? She had swelling in her ankles too, right?
Yeah, but hell, within a year, she'd had 2 hip surgeries.
Yeah.
Mm.
And the one etiology that I don't have in here is and Dr. Kimura had it on his was HMPP, hereditary neuropathy with liability of pressure palsy, which is a gene variant. But there's a lot of reasons why patients could present. There's graft versus host disease.
Yeah.
Mm.
So this is just a case that kind of makes you go, huh? I think that we brought up some really cool points, Bill, on what about and Laura, about pressure on the walker as leading to it. But to me, there's something has to have her. I look at nerves, and nerves are really resilient structures. They should be. I mean, we sit on them all day, we cross our legs all day. We beat our nerves up pretty good. I mean, people use impact wrenches all day on jobs, for years without developing problems.
But
Why? Go ahead.
there's a certain population. I mean, there's a just looking back at some of the patients I've had in the past, that just their nerves just seem irritated, all of them. And all it takes is a little bit of something that's just a little bit of pressure, and then all of a sudden they become pathologic in nature.
And I think the more that we learn, the more that we recognize that that's not normal. You said that there's the certain population that is like that. Well,
Yes,
that's not a certain population of normal people.
absolutely. You're right. You're right. They tend to be female. They tend to be have a little bit more that you can tell by their skin texture almost. It's very, you can pull on their skin, it's like rubbery. You
Okay.
can their posture is not good. Their muscle strength overall is poor. You look at their grip strength. Their grip strength is below normal for women their age. Um, you know, tend to have either a sedentary lifestyle or they tend to be at home. You know, I could think of probably 100 patients right now, just off the top of my head, that could point out these people who have these it's for lack of a better term, they're just pissed off nerves everywhere.
Mm. Yeah, I think I see them too. And it makes me wonder whether there's some type of underlying either one of two things. I think that it's either autoimmune or it's hereditary,
Could be dietary.
possibly. Which they say that the diet's triggering these autoimmunes, all these leaky guts and all this other stuff. Don't know. But at the end of the day, this patient did not have a normal case. She has multiple mononeuropathies of what etiology, I'm not sure. But in a case like that, then that I would refer them on. And again, try to, the things that you guys had mentioned, what can we do to get her off her hands? And what can we do to get her hip strength back in line and hopefully recover? Is this a patient that would do well with, a referral to a neuromuscular specialist or rheumatologist, possibly, maybe, who might delve into some of those other things that you've just talked about? Because something else is going on.
Great patient, Rick.
Make you
The case.
think. Any other comments, questions? Want to talk about anything else?
That was an
I don't think,
interesting case though.
yeah.
Bill, any interesting stuff recently? Laura?
Nothing crazy.
Nothing out of the ordinary. Just a
Okay. Just working.
And
just work.
I had another radial nerve.
Did you? A
Yeah,
bad one?
yeah.
Oh, no.
Couldn't have done it without you.
I'm going to stop the recording.